You're listening to the We Are Libertarians podcast network. Find all of our shows at wearelibertarians.com.
Episode 34, The Paradox.
Welcome to The Paradox with your attending, Dr. Eric Larson. He is a practicing anesthesiologist and clinical assistant professor at Michigan State University College of Human Medicine. Listen in as he takes you behind the scenes of what practicing medicine in today's ever-changing world is like with another doctor. The Paradox is a fun and accidentally informative show for physicians, patients, or anyone who has ever found themselves in a waiting room.
Welcome to The Paradox. I'm your host, Dr. Eric Larson, and today we're going to be discussing direct primary care with Dr. Lee Gross, the president of the Doctors for Patient Care Foundation, and also a managing partner at Epiphany Health in Florida. He's been running a direct primary care practice for quite some time now, and I first heard about him and listened to him give a talk here in Michigan a number of years ago. I'm guessing 2011, but it might have been a different year. But either way, he's been at it for quite some time. He was one of the first adopters of this model, and as those who are regular listeners to the show recall from episodes 2 and 4, where we discussed direct primary care with Drs. Amat and Savage, it's a model where it's a membership fee, and it's outside the third-party payer system. It's an alternative way of delivering primary care to patients, and one in which there's generally more unlimited access to physicians, more time, and discounted rates for laboratory services and radiology services and even medications. I've noticed personally that this has gone from a rather obscure way of practicing medicine to one that is becoming more well-known and adopted by even residents coming out of their training. This is a fairly new phenomenon, and it's a change that has happened very quickly. Primarily, I think it's driven not by the financial aspect as much as it is by the way you practice. Instead of a run-of-the-mill, see patients every 5 to 10 minutes sort of practices with generally lots of mid-levels, you've then gone down to a practice with relatively low overhead, with minimal staff, in a very relaxed setting, plenty of time with patients, and you're able to provide services and practice medicine in a very different way than the traditional way. As you'll hear in the interview, Dr. Gross has done yeoman's work, going to state legislatures and the federal government and testifying on behalf of physicians and patients. He's testifying to allow different ways of practicing medicine and caring for people. Even if you're not someone who practices this way or has a physician who practices in this manner, it's very important that we allow the ability for innovation to occur both at the state and federal level. And any person who's willing to go to legislatures on his own dime deserves a lot of thanks from all of us. All of the show notes will be at theparadox.com/034. You can obviously go to the Patreon page at patreon.com/theparadox to support the show. But without further ado, Dr. Lee Gross and direct primary care. Enjoy. So welcome, this is Dr. Eric Larson. I'm here with Dr. Lee Gross. We're going to be discussing direct primary care. He serves as the president of the Doctors for Patient Care Foundation, which is a national health policy think tank of practicing physicians committed to the establishment of the American healthcare economy and preserves the sanctity of the patient-physician relationship, promoting quality care, supporting affordable access to care for all Americans, and protects patients' personal health care decisions. He's a pioneer of the direct primary care delivery model, frequently speaking at national meetings, conducting media interviews about free market healthcare innovations, and writing articles for national publications. He's a healthcare consultant to physician practices, medical organizations, and insurance groups. He's also testified in a number of formal settings and consulted with CMS, HHS, all sorts of acronyms, Treasury, the United States House and Senate, and multiple meetings with the White House. And I believe you also have testified within your state legislature and others, I imagine. He serves on the board of trustees for a hospital, HCA, and delegate for the Florida Medical Association, and is past president of his county medical society, as am I now, as of a week ago. So, Dr. Gross, thank you so much for meeting with me today.
Appreciate it. Thanks so much for having me.
Yeah, and I actually first encountered you, I guess it was back in, I think it was 2011, with the Other Care Conference in Michigan that our mutual friend, Dr. Meg Edison, had set up. And that was the first time I'd really been introduced to the direct primary care model, which I don't know if you were the first, but you were certainly one of the first adopters of that model.
I certainly can't claim to be the first, but certainly one of the one of the few pioneers out there. And I think when we had that other care meeting in Michigan back in 2011, there certainly was nobody really out there talking about this, nor was there any sort of roadmap or blueprint for how to do this. And so things have obviously changed quite a bit since 2011.
It's amazing, isn't it? I mean, it's only been 7-8 years since then. In what was a novel, and you were a pioneer at the time, and now I certainly feel within the last 1 to 2 years, it has really sort of accelerated sort of the adoption by not only established physicians, which I think is what it initially was, but I feel like there are people coming out of training now who are getting into that. Would you say that's also the case that you're experienced in your role?
Absolutely. So I would say probably in 2011, there maybe were a dozen of us or so around the country that what we're looking at today would have been called direct primary care, but today we're over 1,000 practices, and these are people coming out of training. These are people basically converting their established practices. They're coming from employed physicians and starting up practices as well. So the growth is definitely picking up.
Yeah, we've talked about direct primary care a number of times on the show. I've interviewed a few physicians. I mean, briefly, for those who may not have listened to those earlier episodes, direct primary care is essentially delivering primary care at this point, although I think we're sort of now moving off and out of it's just direct care because there's some people who are not primary medicine, but it's primary care, family medicine, internal medicine, and occasionally you see pediatrics, where it's a membership model, and people pay a monthly fee. They have access to the physician, usually unlimited. Oftentimes they have access to receiving medications if the states allow prescription dispensation like they do in my state, Michigan. And so it's a different way of delivering care without using a third-party payment system. So basically you're not using insurance, you're not using copays. And because of that, you've eliminated a lot of the overhead and a lot of the paperwork, a lot of the computerized health records, the mandatory record systems, which are generally designed for billing purposes. And if you use a computerized system, you're using one that, of course, is for documentation, which is helpful for the patient care. And so it's sort of radically transformed the way primary care is delivered to people. And so why don't you talk about, since you're one of the early adopters, what led you and your partners to adopt this method, or to, I guess, almost conceive of it, right? Because at that point there was really there weren't too many models.
Yeah, there's certainly, like I said, there weren't any any books to read or any conferences to go to or anybody really to pick up the phone and call. So we just kind of walk you through our process at the time. The name of our DPC practice is called Epiphany Health. And in fact, we did have an epiphany. The epiphany was, why are we insuring primary care? Why are we using a very inefficient, very expensive, very impersonal, clunky insurance product to finance and control the most basic aspect of healthcare delivery, which is primary care? And, we were in traditional private practice. We had a full, mature insurance-based practice, fee for service, and we were doing whatever we could to keep our practice afloat, and as you do things in primary care, you really have to do as much to as many people as possible in order to get your billing up. And it felt like we were playing this game of whack-a-mole with the insurance companies because we were trying to find alternate sources of revenue, and we'd start doing stress tests, and then Medicare changed the rules. We couldn't do stress tests. We'd start bringing in ultrasound techs, and we'd start doing ultrasounds, and then they changed the rules on what you can do in your office. And every time we felt like we financially stabilized the practice, the rules kept changing, and we were sort of like, who moved my cheese, and we had to run around and try to figure out how to not go out of business again. And one of the small businesses in town came to us, the owner of a heating and air conditioning company, and he said, Doc, my insurance rates are skyrocketing. And all my employees are all seeing you as their doctor. Why don't I just hire you directly to take care of my employees, and I'll just, I'll pay you to take care of them, and I'll take out a catastrophic policy on them. And even if they, I had to pay their deductible, we'd still save a fortune. And that just got us thinking as to, what do we need to do to work directly with our patients outside of an insurance system? So we did very simple things. We picked up the phone and we called our national lab rep and said, hey, what if we, instead of sending our patients to you with a prescription, and you had to bill their insurance company with the proper codes and then get the codes rejected and then chase the patients down 6 months later after they were finally approved to get their deductibles, what if we pre-collected the money up front and you sent us one bill for all the patients? And they gave us wholesale pricing on our labs, which was about 95% cheaper than the patients were paying oftentimes with their insurance. And then we did the same thing with our local imaging centers. And we said, hey, much like Priceline.com sells unused hotel rooms for, a low price to guarantee the sale, what if, if you own your CT scanner, what can you sell a CT scan for if that scan's going to go unused? What can you sell an unused MRI slot for? And we were seeing, CT scans for $175 and MRI for $220. And the more we reached out to our independent operators and independent cardiologists and independent rheumatologists, the pricing that we were seeing for these services with not using insurance in most cases was actually lower than the patient's responsibility using their insurance. And the interesting thing happened is when we started launching this new practice model, patients started coming to our independent practice from all over the state of Florida. I'm in Southwest Florida, and patients would come to us from Miami, from Orlando, because they could afford what it was that we were doing. So that practice just exploded. It caused interesting things to start happening. So now that we're seeing uninsured patients coming to us, it became obvious that insurance was a barrier to accessing quality medical care. It was no longer a vehicle. It was no longer the tool that you need to get care. It was actually the obstacle to getting care. And our patients without insurance were actually having better luck getting care than our patients with insurance. Yeah. So it really has been a eye-opening and fascinating transformation just right in front of our eyes.
Yeah, it's interesting how the fact that it with the increase in price of insurance, it really spurred this on, right? I mean, it was not by design that the insurance rates would go up, and it forced this sort of market response. But that's exactly what has happened, right? It was had insurance copays and premiums remained low, I can say low, but they weren't that low. But to the point where people weren't having the bank broken on them, this movement probably never would have launched. Although I think when you see people who adopted it, they were initially probably moved in the beginning from the price point standpoint, and maybe it's the overhead reduction. But I feel like the appeal to it now is almost more the way you practice and the relationship you have with the patients more than it is sort of the financial and the economic aspect of treating patients.
Absolutely, I would agree with you. I mean, it's a practice model where it seems like all the incentives are now properly aligned. You're actually working for your patient, and the patient is the customer. And you're not having somebody else who has financial interest guiding that decision in the middle of it. There's no third parties. So it really allows the doctor to be a doctor again. The 5-minute office visit is a thing of the past. It's as much time as you need for the patient. And because you don't have, a $50 copay for each visit, the patient may come in, so when the patient has a $50 copay, what they're going to do is they're going to come in with a list of 200 things that they want to talk about because they're going to get their money's worth out of that visit, and if you bring them back again in 2 weeks, it's because the doctor wants to get more money out of me. Whereas in the direct primary care model, patient brings a laundry list of concerns, which are all important to the patient. You can very comfortably say, let's pick the top 3 things that are bothering you, and we'll address those, and then come on back in 2 weeks. And we'll address those other things that are also equally as important to you. But if we try to address all of them, then we can't do it properly.
Yeah.
And it just makes it, obvious that you're not just doing that because you can get one more copay out of the patient. You're doing it because that's the proper way to care for the patient. Or right. even more so, the patient that calls up and says, I've had 5 bladder infections in the last 5 years. I know what they feel like. My bladder infection is starting. Can you call me in some Bactrim? And the answer in a fee-for-service practice is absolutely not. You must come in. Why? Because that's the only way you can get paid.
Right.
And you can't stay in business by working for free, even if it's the right thing to do. So, whereas in a DPC practice, you're already being paid. So why can't you just do the right thing? And again, the incentives are aligned to do the right thing.
So I think when you came and spoke, you mentioned that you work, I think you were working like in Charlotte County. Is that right? Is that correct? But where Punta Gorda area in Florida?
That is correct. Yes. Officially North Port, which is southern Sarasota County on the Gulf Coast.
Yeah, I only remember that specifically because that's where my parents, they winter in Punta Gorda. Okay. And I remember you commenting at the time that you thought that you maybe said that Charlotte County is where all the old people in Florida, that's where all their parents live. And when I visited them,
yeah.
I agree that is. Yeah. And so, that leads you to think, well, how do you have a practice in Port Charlotte where presumably the majority of the population are Medicare? I mean, how are you getting Medicare patients to show up when they have totally free health care?
Yeah, in full disclosure, it was only recently that I opted out of Medicare. So that was a relatively new development in our practice. We were running a hybrid for some time, but now our practice is officially a completely insurance-free and opted out practice. Frankly, the patients appreciate the care. It allows you to truly be the doctor you trained to be. So when you have 5 minutes for an office visit and the patient comes in with a complex problem, even if you're capable of handling that problem, the timing of it basically mandates that you refer everything out. Everything goes to a specialist, whether you're capable of handling it or not. And in a DPC practice, if you have 30 to 40 minutes per office visit to spend with these patients, then these complicated cases that you're capable of handling don't need to be referred out. So, which is an interesting phenomenon because, in a fee-for-service third-party practice with 5-minute office visits, a physician and a nurse practitioner or a physician assistant are basically all equal because in 5 minutes, they're all going to do the same thing. They're all going to refer out. Right. In a DPC model where a doctor has time, then that 22,000 hours of additional clinical training really are allowed to shine. And many things can be done within an office visit that normally would have been referred out by, perhaps a physician assistant. So it truly allows the doctor to practice to the fullest scope of their training. So that includes, removing skin cancers in the office, or procedural-based things that we can do in the office, again, managing more complex conditions. And so the Medicare patients, I think, appreciate not being bumped around from specialist to specialist to specialist.
Right. They can get, one place can handle most of the problems. Obviously, you're not going to do a heart cath, but you can probably manage hypertension and lots of other problems that would sometimes go to a specialist. You've testified all throughout the country and a number of times in D.C. I feel like on Facebook I'm always seeing you sitting before some Senate panel trying to get some aspect of the Affordable Care Act changed or the addition for direct primary care to be allowed to use by HSAs and things like that. So you've spent plenty of time with legislators, and thank you for that since most people don't like to spend time with legislators. What have you found to be the biggest objections to the direct primary care model from legislators who probably don't understand healthcare to begin with, but really don't understand this model? And then what's your rebuttal to these objections and questions?
Yeah, I would say probably the biggest objections are from the people that truly don't understand what it is that we do. The biggest objection, I think, is that this is care for the wealthy, and that direct primary care doctors will cherry pick the healthy, leaving the sick for the government or for the insurance companies to take care of. That's probably the most common criticism that I get, and frankly, it couldn't be further from the truth. The patients that are perfectly healthy, quite frankly, don't want to pay a monthly membership fee to not see their doctor.
Right.
And so it definitely attracts the patients with more chronic and complex medical conditions. There's no doubt about that. And I would say the majority of the patients do have at least one chronic medical condition. And the concern is, when a patient is sick, then we're just going to go ahead and cut them free because it's not profitable for us to have sick patients in the practice. And while there certainly are some high utilizers, it's never usually the same person every single time. So some years you're going to be the high utilizer, but it's never really consistent. So that top 1% of utilizers is going to change from year to year. So if you constantly cut out your sick patients, you wouldn't have a practice. It defies logic to say that you're going to build a viable business model where your business practice is to fire your best consumers. It just doesn't make sense, and it doesn't play out that way. So that is absolutely a non-factor in the practice.
So that I think one of the things that I came away with at the conference a number of years ago is you spoke about how DPC really provides an avenue for the poor to receive healthcare that they're not able to get normally. And I think most lay people will think, oh, well, there's Medicaid and there's opportunities for people to get plenty of healthcare now, especially if it's been expanded in states like our state of Michigan. It was expanded, added a couple 100,000 people, maybe even 1 million people, I can't remember, to the insured rolls. But the contention is, well, yours is obviously expensive. I mean, these people have nothing. How can they even afford to pay the, if they've got diabetes or buying their insulin, how can they afford the membership fee? But what is your response to that? I know you said, how do the poor afford this model, and how is it actually superior to, say, receiving free Medicaid services?
Yeah, so here in Florida, we did not expand Medicaid, but I can tell you that the closest doctor to me that's accepting new adult patients, primary care under Medicaid is about 2.5 hours from me. So, you can give somebody pretty close. So, just because somebody has a card does not necessarily mean that they have care. And I think that's something that we found out really fast is that, coverage is not healthcare. And just because people have coverage under Medicaid does not mean that they have primary care or they have access to services. They have access to the emergency room, which is the most expensive place on the planet to get primary care. When we set our prices for our practice, at the moment we're $65 a month for adults, $25 for one child, and $10 for each additional child. That is cheaper than I pay for my cell phone. And I think, most patients that are on Medicaid, if you look, they probably have at least one cell phone, if not more. Yeah. And if you can afford a cell phone, you should be able to afford basic medical care. And, our position was, let's just make the routine stuff affordable for everybody. And let's stop trying to cover everybody. Let's go ahead and just get everybody access to basic medical care for cheaper than a cell phone. If we can do that, I think we've gone a tremendous way towards solving some of our issues in healthcare. It doesn't solve all of them. I don't claim to solve all the problems. But if we could get the routine stuff out of the ERs and back into the doctor's offices, I think we'd go a long way towards getting access to affordable medical care for most Americans.
It's interesting that and I don't remember how the legislation played out in Michigan, but there was a push for a while to try and get direct primary care as allowed for people with Medicaid to see a direct primary care, to pay those fees. And there was a lot of resistance within the state from the usual suspects you'd expect, right? The insurance companies, the large hospital healthcare systems, because they don't own and control any of these services. And I think not only do they want to try and maintain those patient volumes, but I think they probably want to prevent that model from widespread adoption, because it certainly exposes a lot of things. If you can charge 95% less for laboratory services, it shows that the amount of, I don't know if I should say waste, but it certainly shows the amount of administrative expense in using the third-party payer system for getting anything, whether it's laboratories or imaging, and so I think they don't want to lose that monopoly, right? And so I'm sure it's the same in Florida and elsewhere, that there's just a lot of resistance within these large healthcare systems to try and minimize or at least disparage the direct primary care model.
Yeah, it's complicated. There's no question about it. I was involved in many of those early conversations up in Michigan about the direct primary care and the Medicaid. working with the state legislature, and I spoke to a lot of Michigan lawmakers on the telephone, in the years going up to the direct primary care law passages, and I'm happy to sort of share some of that. But we talk about efficiencies of government-run healthcare versus private healthcare. In my recent testimony in the U.S. Senate, that was actually one of the things that was brought up by Senator Alexander, the chairman of the Senate Health Committee. Is they're paying almost $4,000 per year for each primary care patient to be treated in a federally qualified health center, and my cost is just over $600. So why is it 10 times more expensive to treat a patient in a federally qualified health center? It's because the regulatory burden it's enormous when you're dealing with a government entity. One of the things I talked with the lawmakers in Michigan about, my recommendation to the Michigan lawmakers, and actually to anybody that asks, but at the time my recommendation was give the patient an EBT card, just like they would have for food stamps or for the grocery store. When a patient with food stamps goes in the grocery store, they pull out their credit card that's loaded with benefits and they scan their credit card. And nobody cares who put the money on the credit card. The store doesn't care who put the money on the credit card. They're just like any other consumer. So why can't the patient have a state-funded or federally funded credit card that they shop around to TPC practices? Allow the patient to be the consumer. Allow the patient to be an empowered person within the system, as opposed to a powerless person that just does whatever the state and federal government tells them to do. That then properly aligns the incentives, where the doctor then has to compete for the patients. They don't have to compete for a government contract. The government doesn't set their prices. And if the patient controls the account and then has to go to the doctor that provides the best service for the best value because it's their money, that allows the doctors to then adjust their practices based upon what the patient's needs are, as opposed to what the payer's needs are. You don't need any crazy metric reporting for that. You just need to basically do the right thing. And the pushback that we got from that, you would have thought I was speaking Chinese. By, what do you mean we're not going to control the money? What do you mean you're going to put the money in the patient's account? What do you mean that, the patient will determine what the quality is? How is that possible? How does the patient know what quality healthcare is? They're not smart enough to know what a good doctor is because they don't have the data behind it. And it was a lesson in frustration, as is most work with any government agency.
Yes.
But, I think, at the end of the day, it all comes down to money and control. And once you lose control, you've lost a lot. And I think that's frankly one of the biggest fears from the insurance companies about the direct primary care movement is if you lose primary care, holy cow, there's so much that would follow that. So they do need to continue to keep primary care under their thumb, or they've lost a lot of control.
Yeah, it's interesting. I feel like not only do the legislators feel this way, but I'll just call it the elite in society, certainly see the poor. They're very paternalistic and I would say also many physicians, especially academic physicians, see the poor as helpless and not understanding how to get through life. And yes, they may perhaps they're impoverished because of bad financial decisions or life decisions, but these are not generally stupid people. And so it is a shame that they are treated as if there's no way they could possibly make any sort of decisions that are rational, and determine quality of care, or determine, if the person they're interacting with is doing a good job. It's kind of sad. And I think one interesting thing when you're talking about the primary care and the ability to have more time with patients. So now the more routine things that get sent out to specialists that you don't need a specialist to teach you, to instruct the patient or to treat. Now you're taking care of those as a primary care doc. You almost need more primary care docs because you can take care of more things, but then you need less specialists, and specialists are definitely big money makers for lots of these healthcare systems. And it would probably realign what's going on in medical school somewhat too, right? Because I think right now it's hard to get people to go into primary care because of the tremendous expense and the way you have to practice. So,
well, yeah, you take an oath of poverty, basically, and you're, the lowest person in the pecking order. Frankly, I think a lot of specialists really could be primary care. Why can't an endocrinologist be a primary care doctor for a diabetic patient? Why can't a nephrologist be the primary care doctor for a dialysis patient? They basically are. They're handling all of their day-to-day medical issues and managing most of their medical problems anyway. So, that basically transitions them into primary care. And that, I think that's, to your point, that's probably another one of the criticisms of the direct primary care movement, because since you're seeing less patients, you're exacerbating the primary care shortage. And I'm not really sure there's a primary care shortage as much as there is a misalignment of incentives that forces people to go into specialty care. But if you eliminate the administrative burden, the number of hours that physicians, particularly primary care physicians, spend on paperwork as opposed to patient care, if you eliminate that, just the efficiencies of doing that allows almost adding enough full-time equivalents of the primary care doctors to solve any perceived shortage. Just stop treating the chart, stop treating the insurer, stop treating the payer, and start treating the patients. And all of a sudden you have an equivalent of many more primary care doctors available.
Sure. Yeah. I mean, if you cut the paperwork in half, you've doubled the amount of primary care. And I think I don't think people recognize, and I don't even think many physicians really, unless they sit down and think about it, how much their practice and how much the way you do things is really dictated by incentives. And I'll say incentives, although it's pretty much, you get 100% if you do what we say, you get otherwise 70%. So it's not like any enhancement of your payments, but how much is dictated by algorithms and by metrics that may not actually apply to your particular patient, but you're doing things because there's, you need 48% that are going to have the, seen by within a year for whatever, even though maybe things you could manage without seeing someone, So, go ahead.
Yeah, and so you're not only that, or you have to hire staff to do those things, and that costs money. And so what ends up happening is that the doctor becomes so busy trying to run as many people through the practice as possible that you have to hire staff to be the roadblockers to keep patients from bothering the physician. And that was one of the things that we've quickly realized, is that we can now hire staff to facilitate the patients communicating with the doctor as opposed to replacing it or blocking it.
Right.
And instead of hiring staff to treat the insurance, we hired staff to treat the patients. It was eye-opening, the transition. And the staff basically became the conduit to communication with the physician and not the blocker.
Right. Well, I mean, my wife's a pediatrician in a traditional single specialty primary care practice. And for her, I mean, they have people who they have hired pretty much where their full-time job is to work on prior authorization, to make sure they deal with the insurance companies, to make sure that the medications they prescribe and are approved by the insurance company, and they have to call and get permission, where they're almost always approved, but it's just an extra added administrative step. And, you add 2-3 people into a practice that's maybe 40 employees, you've increased the cost tremendously. Now you're forced from a financial standpoint, you've got to either move more people through, or you've got to do something to pay for that person. And oftentimes you're not getting any added revenue from this. It's just an administrative burden, and also contributes to burnout and other sort of things with the physicians.
Exactly.
Do you see with you kind of touched on it a little bit with the DPC docs, and also maybe having a nephrologist as your primary care, as your role with the president of the Docs for Patient Care, do you see now more specialists moving to this sort of, I guess a model? I mean, it's supposed to be like a membership model, or what do you think that's going to be something that's the next sort of transformation of this movement?
It is. I think everybody's watching very closely what we're doing. And I don't mean me. I mean, we collectively, the DPC movement, right, of what we're doing. And they're very interested. And the more people that adopt it, I think the more people are interested. So there are definitely, some pioneers out there that are, that are doing this in specialty care. There are some pediatricians that are doing this. Becomes a little bit more complex in the pediatrics, specifically because the cost of the vaccinations becomes a major issue. Probably one of the leading obstacles to uptake by pediatrics practices. I think we're seeing some endocrinologists start to roll into this, and then we're seeing some procedural-based specialists, some surgeons that are not necessarily doing membership-based like the DPC is, but they're doing a insurance-free practices. So you see, some dermatologists that are doing it, some anesthesiologists. As you probably know, the Surgery Center of Oklahoma probably comes up often on in your conversations. I don't know if you noticed recently, but a free market emergency room and hospital just opened up in Oklahoma City.
They're on my list for my next interview.
Yeah, so it's happening. It's slow, but we are definitely paving the way to make it easier for them to do this. And you're absolutely right. As these insurance plans get more and more costly as the deductibles go up, basically every patient is now a self-pay patient. Whether they have insurance or not, they're a self-pay patient. So they're forced to look for value, and they're forced to look for cost. And the physician practices that embrace that and are transparent in their pricing and are fair with their pricing will have a competitive advantage in the near future. Yeah,
I think you're right. I think the challenge, of course, as many people know, that you're not allowed to have you have to have a rack rate if you're going to be using insurance, because there are a number of contracts you might have with the insurance company saying, well, you pay 60% of our rack rate for whatever it is we're doing. And so you then can't say, well, somebody comes in and pays cash. Well, you can just pay half of, what our rack rate is or whatever, because you're in violation of either federal laws or your contracts with your third-party payers. And so it makes the transition very difficult for specialists and surgeons especially, and anesthesiologists, people are related to that sort of thing. But I think the price points are certainly forcing people into finding solutions. I had a question about you're doing lots of testimony and you're not doing it all the time, but you've spent a lot of time with legislators. Yeah. And you've been a member of your county medical society, and I know you've been active in the Florida Medical Association, which is, I imagine, the state medical society. And I've been involved also in our state here in Michigan. Most docs are very busy. They don't have time for this nonsense of talking to people who don't know anything. You're talking to like a real estate agent who's now a state legislator, and to try and explain in 5 to 10 minutes what you're doing, they don't have. It's really a tough thing, and especially when they come with their preconceived notions and whatever. But how important is it for docs to get involved in organized medicine? And I don't mean organized like we're out with picket signs, labor unions, but
right.
Organized medicine refers to medical societies and like the AMA, because lots of docs are just turned off by the direction of lots of these organizations. And so what do you say to them is it worth doing it? If you do it, how do you do it?
Well, I have mixed feelings on this particular issue.
That's honest.
So doctors absolutely need to get involved. There's no question about it that doctors need to step up and become engaged. That's why we're in the position we're in. And for docs not to get involved in policy, that's when you get a realtor that's basically making health policy decisions. And that is precisely why we created the Docs for Patient Care Foundation, is that, when you go into all these health policy conversations, you find that nobody at the table really has any idea what the heck they're talking about. Yet they're the ones that are making all the rules for the entire country's medical practices. So we created a health policy foundation that basically puts practicing physicians at the table in these conversations. So we want somebody that's truly the expert in the room during these conversations, and that's the role that Docs for Patient Care Foundation has played. But we also need physician advocates working their way through the county medical societies, the state medical societies, the American Medical Association. We need, true physician and patient advocates working through this. But if you think about what it takes to get stuff done, if you want to be leadership, let's say in the American Medical Association, you probably first need to be a county medical society member. Then you have to work your way up through hierarchy of the county medical societies, get yourself as a delegate, working your way to the state medical societies, spending years as delegates, working your way onto the committees at the state level, working your way through leadership in the state medical societies, then becoming an executive through the state, which can then get you as a delegate to the American Medical Association. With years of building credibility there, you can get yourself on committees and through leadership there. That's an entire career before you actually are at a level where you can truly have a voice. Whereas with what we're doing, I'm 2 phone calls away from the head of CMS. We make a phone call and I have a meeting with the Deputy Secretary of Health and Human Services. And so they're all important. And just because I have a meeting doesn't mean I have a huge voice. My voice is one physician voice, whereas the AMA, claims to speak for 800,000 physicians, and they do so because they have representation from all of these organizations that are delegates to the AMA, even though most physicians in the country aren't AMA members. But I would imagine that the AMA voice is much louder and should be taken more seriously than a single person in the room. But a single person in the room talking to the right person can move mountains.
Yeah. Well, and I would just speak from our experience in Michigan here. Dr. Edison and I have been, champions of the reform for maintenance certification in the state of Michigan. And, we both got involved in our county medical society. And then by extension, you end up in the state medical society and you go to the conventions. And there is ample opportunity to be a delegate, to interact with the staff. And it turns out that most people in these societies that I found are, I don't want to say old, but they're not at the beginning of their career. And so if you've got energy and you've got ideas and you've got gumption, it's not hard to inject yourself in these discussions that will land you in Lansing or your state capital, where you can be making important policy, just having important policy discussions with people who are making law changes. And so we've had people testifying. We've ended up moving the medical society because it turns out the medical society wants to please people. And if you're the one who seems to be with all the energy and the grassroots support, because you get a couple petitions signed by a couple hundred docs and stuff, they're going to start working for you. And then they have, as you said, the organizations have a larger voice and gravitas than an individual walking up into the state capitol. But they are they're going to be responsive to the people who are responsive in their organization. So you can have a fairly outsized voice by just being active in your society, and then that society has that gravitas and that impression that they represent all the docs, right? Like the AMA, as you said, to try and become the president of the AMA, that's super hard. But to get legislation or to get resolutions to the AMA is maybe not quite so hard. And then you can if you get a couple people, you can maybe push them to change their agenda. And whether you like the AMA or not, if you're a doc, they are sort of seen as the face of physicians in Washington, right? I mean, so I guess you can either sit on the sidelines and I don't know. I don't know what the right answer is because I feel the same as you do, because the AMA, I think, has taken some positions that are contrary to physician well-being. And so
absolutely.
It's hard to support, right? That's why they have so much trouble, but they have outside revenue sources, et cetera, et cetera. But so you'd say get involved. I mean, I would say it too, even though sometimes you just kind of have to hold your nose.
Yeah. And, a lot of these delegate seats go unfilled.
Yeah,
which is,
absolutely.
When you consider the sad state that our profession is in, to see that positions of representation are unfilled and empty, it's infuriating. Yeah. You just can't fill just fill the seats. You can get your butt to the meetings and represent yourself and represent your profession. Take back control. And unfortunately, we're in a position now where more than half the doctors in the country are employees. And they've disengaged. And we need to re-engage. So I'd love to talk with you about some of the policy issues that are sort of affecting direct primary care. If we have a few minutes
Absolutely.
to talk about
why
that.
why don't you talk about why don't you just go ahead through your agenda, your legislative agenda that you've been working at in DC and elsewhere.
Right. So, the obvious question is why would a DPC doctor need to get engaged with the legislature? You're an insurance-free practice. Just do your thing. You don't need to get involved in politics. And I think the most significant issue affecting DPC docs is, if you charge a flat monthly fee for what essentially amounts to unlimited primary care services, aren't you a risk-bearing entity, and shouldn't you be regulated as an insurance company? And if you're selling memberships, shouldn't you be regulated as an insurance salesperson? Shouldn't you be licensed as an insurance salesperson or a benefits consultant? And so we have worked in many states and through organizations that promote policy to pass legislation that says that if a doctor and a patient contract directly for a membership fee, then the doctor doesn't become an insurance company. The doctor is exempt from regulation as an insurance entity. And so similar legislation has passed now in 25 states, which means that half the states in the country still don't have protection of doctors that set up practices like that. Mm-hmm. There's nothing to say that these practices are illegal, and in the rare instances that the doctor has been challenged on it, the doctor usually does win the challenge. The question is, does the doctor have the financial stability to withstand that charge? Can they survive a cease and desist letter from the Office of Insurance Regulation in their state? Mm-hmm. And so we try to preempt that by getting out in front and passing this legislation. So we'd love to see the other 25 states passing legislation. Michigan, with the leadership of Senator Pat Colbeck, was one of the early adopters of this legislation.
Mm-hmm. Right.
So the major issue now, I think, at the federal level, there are still some state level issues like, doctors being able to dispense medications. I think 6 or 7 states still ban that. But the federal issues go around the tax treatment of the DPC memberships. So I'm not sure most people realize, but the IRS has taken the position that DPC memberships are essentially the only healthcare service in the entire country that is not eligible to use a health savings account or health reimbursement account to pay for it.
Actually seeing a doctor.
Yeah, so you're actually paying a doctor directly, but that, because it's not a fee for service, is considered to be by the Internal Revenue Service, or I should say by the previous commissioner of the Internal Revenue Service. He declared that DPC is a health plan, and therefore you can only have one health plan with an HSA, and it has to be a compatible health plan. A DPC would be a second health plan. Not only can you not use your DPC, or can you not use your HSA to pay for DPC, but if you as much as join a DPC, you are disqualified from owning and contributing to a health savings account, according to the IRS. That is absurd. And that is the strictest interpretation, and it's never been enforced, and it's never been challenged. And I firmly believe that their position is absolutely, completely, 100% wrong. But it is the only position officially in writing by the IRS, is that it's incompatible. So legislation has been proposed at the federal level multiple times, called the Primary Care Enhancement Act, that basically establishes DPC as an HSA compatible expense for HSAs and HRAs. That has almost gone nowhere. It did start to move last year. I suspect that this year, this legislative session, you're going to start seeing a lot more interest around that topic. I can tell you that the present administration is very, very, very much supportive of direct primary care. They truly want to see a regulatory fix for this HSA and HRA issue. Unfortunately, the Treasury is still digging their heels in and pushing back on this. And so we've had meetings with Treasury, we've had meetings with White House, we've had meetings with the Office of Management and Budget, National Executive Committee, and I think you're going to see some regulatory fix for this, hopefully, but we really need a legislative fix once and for all. So that is, something if people want to be supportive, is supporting, Primary Care Enhancement Act, looking for that legislation to start moving this year. I think in the next couple of weeks, you're probably going to see another hearing on primary care in the Senate Health Committee. Senator Alexander has very much expressed a whole lot of interest in supporting this idea. So I think you'll see more support at the federal level. So I think, again, people need to get engaged. They need to watch out for this. They need to encourage their lawmakers to support these initiatives, because the crazy thing in Washington is that they have this perception that your money is their money, and therefore if you're keeping your money, they're losing money.
Right.
And they put I think a $2 billion price tag on this HSA fix for DPC, which is an absurd figure, which we could spend an entire day talking about CBO scoring and how, the assumptions they make in that. But no way on earth that this is a $1.8 or $2 billion loss to the federal government by giving people access with their own money to primary care.
It is interesting, though, that you can have an administration that would support it and actually controls the other parts of the administration, which would say be the Treasury Department, and yet they still can't get regulatory changes. It's just I think a good example of how the bureaucracy works, and this is not unique to the federal government. I mean, it's the same at the state levels as well. But so about half my listeners are not physicians, and there are either affiliated healthcare people or just lay people who are. I really hate that term. It makes people sound like they're stupid or something. But the people who are not, who aren't in the healthcare arena, I guess, outside of being patients. So for them, where would you direct them? I mean, they're not. Do you have them writing their congressmen, their state legislators? Do they go to the direct for docs for primary care? Is that the best place for them to kind of lend support?
Yeah, I mean, if they wanted to look at the work of our organization, they can go to our website. It's again, Docs for Patient Care Foundation. It's 4 PCFoundation.org. We are a 501c3 tax-free nonprofit organization. So if they want to make a tax-free contribution, they can to support our efforts that we do around the country. And again, they can sort of engage their lawmakers and tell them that they want to support the direct primary care.
And where would you recommend people find out about this? Because I've had a number of people contact me in email and say, hey, this sounds really cool. Where can I find it? I'm like, I don't know. I Google it, I suppose. Is there a place where people can find direct primary care practices and maybe not only support this, but maybe just experience a different way of getting their medical care?
That's it. The most comprehensive database right now for direct primary care practices is Dr. Phil Leskew's website. It's the DPC Frontier, and I think it's dpcfrontier.com. And he has a mapper on there where you can pull up a map and see the DPC practices in your area. And he's adding more and more robust features on this where you can actually see specifics about the practices and their price points and the services they offer.
And finally, do you find yourself speaking more to medical students and residents over the last year or two?
I personally am probably speaking less to the medical students, although there was certainly that interest. Right now, I'm probably doing most of my speaking to lawmakers, policy people.
Okay.
And, so for example, next week, I'll be giving a presentation in Las Vegas at Caesar's Palace to the National Meeting for the Healthcare Administrators Association. So this is going to be 500 independent TPAs, self-funded businesses, and people that are driving the health plans for most of the large and medium-sized businesses in the country.
So those are like insurance companies that are going to be there?
These are plan benefit designers,
okay.
Brokers, basically people that are putting together health plans for employers. Right.
So you're like an employer that you have 500 people on the factory floor, and you're looking for a way of providing health care for your people and not having to use the traditional, maybe the local insurance company or whatever, like the health plan, right? So you're just sort of almost designing your own. Is that something you see docs doing now, where they just say, hey, I'll be the doc for 1,000 people, and that's just my job? like almost like a factory, like a company doc.
I don't think that's a common thing, but it's definitely picking up steam. The employee on-site clinics, near-site clinics are definitely a thing. There's even mobile docs that'll bring their RVs up to the company. I think the person that gets this right for the small businesses, the person that's going to revolutionize healthcare in the country. So that's most of the employers in the country are small businesses.
Yeah.
So
right.
to one small business, one doc could definitely change the healthcare landscape. And that's one of the things that they did again at the federal government is they changed these association health plans that allow small businesses to consolidate together and to act as a large business to purchase. And so if we could allow the DPC practices to work with these small businesses for the routine care and then allow them to consolidate, to pool their risk, to create, wraparound plans or catastrophic plans in an affordable manner, I think there are some unique opportunities here.
Right. Because the key with direct primary care is you still have to have insurance. Well, it's highly recommended in case something happens that can't be handled, right? Like if you need an appendectomy, you're not going to go to your direct primary care doc to have it taken out in his office. You're going to obviously have to go to the hospispital.
You're not going to shop around your heart attack.
Right.
Get that.
Yeah, pretty much wherever the ambulance rests, that's where you're ending up. Well, I appreciate you stopping by and taking a few moments out of your day to talk to me about these things. Where is a good place for people to follow your activities and all your testimony?
So everything you can certainly get on our emailing list at Docs for Patient Care Foundation. Again, D4PCFoundation.org. You can check out our practice website, my personal practice website. That's epiphanyhealth.org. It's EPIPHANY health.org. And there's lots of information. You can follow me on Twitter at Dr. Lee Gross, DRLEEGROSS.
All right. Got to use the Twitter. And all right. Well, that sounds great. And again, thanks so much for being on with me today. And hopefully we can keep moving things in the right direction. I think we're transforming healthcare one doctor at a time.
I appreciate you shining some light on this. Thanks for talking about it.
Thanks for listening to The Paradox. If you like what the doc is doing, please subscribe and leave a review on iTunes or Stitcher. And share the show with your friends. Become a supporting listener to get access to special bonuses at patreon.com/theparadox. Show notes can be found at theparadox.com.